on the live event, and then I'm going to promote myself to the live event too. Well, good afternoon, everyone. This is Scott Brunner. I'm the Deputy Secretary of Hospitals and Facilities with the Kansas Department on Aging and Disability Services. Thanks for dialing in this afternoon to attend our webinar on long-term care issues related to testing for COVID-19, vaccination, and visitation. We've had a couple of these over the last couple of months, and I found them very valuable to get some information out, links to other resources. So we're happy to keep that trend of things running here through April. And glad that you decided to join us this afternoon. We are using a slightly different platform through Microsoft Teams. This is the first live event that I've run through Microsoft Teams, so I appreciate your patience as we kind of figure out some of the technology as we go through as well. It works a lot like Zoom, but there's a couple of differences. And so I want to just take a minute and talk through those. But before I do that, also on the webinar, there are a couple of other presenters. Lacey Hunter, who's the Commissioner for Survey and Certification at KDAD, is also on the webinar listening and helping me with questions that'll come in through the question and answer area. And we've also got Heather Pilkington from Presbyterian Manor here in Topeka to share a little bit of her experience at her facility with visitation through the pandemic. And one of the things that I wanted to introduce in this session was some experience from the field and kind of best practices, and have some discussion about that, again, to share that information with you. So they'll join throughout the meeting after I've done the basic part of the presentation, and then we'll close up for the day after Heather's had a chance to present. Just a couple of logistical things in Microsoft Teams. Again, we're the only presenters, only the presenters are able to speak, so I apologize for that. Couldn't figure out how to make it more dynamic than that. But you as an attendee can type in a question in the question and answer area, which you should be able to see on your screen. You can type those questions in either with your name, so we know who to respond to, or anonymously, which either one is fine. And then when we write a response back, we publish that back to the group, so you'll be able to see that also in that same window. Then we may try to answer some of the questions live over the video or over the audio channel. We'll see how that works out going forward, but we will try to capture all of the questions and make sure we have those responded to as we move forward. So again, thanks for signing into the webinar. I'm going to use that same email list to send out the slides, so you have those after the meeting, and that way you'll have the slides, the content that's on the slides, and all of the hyperlinks that you'll see back to other resources. So that'll come after the meeting. And then in prior webinars, we've done some frequently asked questions on the slides. I took those off for this one because we have some updating to do because of the new visitation guidance. We'll get those updated along with some other guidance documents and get those out next week and updated, but you won't see those on the slides today. And then the last just overall kind of logistical comment I had was about if you want to watch the video later or send it to somebody else, there is a way to do that through Teams, and I have figured out where that download is available. And the two things I've observed is that if you come back to the same link after the meeting is ended, you can watch the video through Teams, but we also have a way to download it, and we'll put that up on the website once I figure out how to do that. But that maybe will take a couple of days to get that figured out as well, and we'll post that to our COVID-19 page on the KDAD's website. And again, I've gone through my notes. I already talked about how the questions would work. So hopefully that would work, and I see some questions already coming in, and we'll work through those as we go forward. And thanks for the couple of comments. So the only chat way I can see if there's a problem with the video or problem with the audio is if you type something into the question and answer box. Feel free to use it for that in case there is a problem with the video or audio or something technically that that needs to happen differently. So with that, let me jump into the slide presentation here, just with the agenda. I want to talk a little bit about some topics we've covered before. I want to give you an update on long-term care testing support through the state testing strategy, and also our status report that we've been collecting information on from facilities about your testing status. Give you a quick refresher on obtaining Abbott Binax Now antigen test cards from the Department of Health and Environment if you need a supply of those or need a restock or more of them so that you can conduct visitation. Wanted to make sure everybody had that information at their fingertips. And then also what we talked about last month with reporting the results of those tests through the KDHE disease reporting portal or lab exchange. I wanted to make sure you had that. Then kind of the next major topic, the updates on testing frequency and visitation guidance that came out on Wednesday from CMS. Talk through a couple of the highlights with that, and then finally wrap up with some of the best practices on visitation that Heather's going to share. And then if there are some things that come in through the chat that you'd like to share as well, we'll talk about those on the slides. So yes.
Sorry, it seems like in the chat we have some people who can't hear. It seems a lot of people can't hear the audio, and then a few people who can't see the slides.
Okay. I can try to send it out live again. Can you hear the audio okay?
I can see, I can hear and see, but we're getting, a couple people from Leading Age said, no, one said no slides, no audio, one's audio, no slides. We have people who are dialed in on the phone and still can't hear the audio.
Okay. Try to promote it one more time and see if that does anything different. But otherwise, I don't see anything else that I can do to change the audio part. I'm not muted.
It says that possibly switching to full screen might help you see the slides. So if you're having trouble seeing the slides, maybe switch so that this is full screen for your computer. Polly gave that suggestion.
So okay. So I've just made it all full screens and taken off my video. Is that going to help?
Would anyone give us some feedback on if this has been resolved?
There's a couple of comments saying they can see and hear both, so I think we probably just need to proceed and hopefully catch them up on the recording.
Okay.
And Lacey, Jennifer from Leonardville Nursing Home had a comment in as well. I guess can you see if she can dial in on the phone number the way that Heather did?
Yeah. Okay,
thanks. So we'll just try to again thank you for your patience and I appreciate your willingness to walk through this with us. But I think the recording will work. So if nothing else, afterwards you can watch this again, which would be painful for me, but hopefully it's information that you all can use. So on testing, so this is the same slide from last time, the statewide testing strategy with the regional labs that provide the PCR viral level testing will be available through December 31st at no cost. That's important to have as a resource available to facilities, and hopefully you've got relationships set up with those regional labs. And again, that'll be available at no cost through December 31st. I did hear from the testing team that they may start trying to gather some information about residents' insurance status for billing purposes. I got kind of lots of comments about being able to see and hear, so thank you for that. So they may start trying to gather some insurance information at the lab level, but I'll keep you posted on what that looks like going forward. But again, the goal is that there's no cost, certainly to residents or facilities for that testing. I did want to point out on the topic of testing, even in the new CMS guidance about testing your staff and frequency, it is tied to the county positivity rate. The higher the county's positivity rate for test results for COVID-19, the more frequently you need to test your staff. And then we pointed throughout the pandemic to the KDHE KDHE data and their maps. They've moved those resources around a little bit. They from time to time shuffle some stuff on their website to highlight some things and move other things around. So I put the website link up here where these resources are, and on this first part on the left-hand side shows you what I clipped out kind of the top part of the slide of the screen, but at one point you get to this kind of menu of 12 gray boxes that have a variety of titles on it. So from that first page, you click on where the county positivity map for nursing facilities and long-term care settings is under COVID-19 metrics. So you would click on that part of the window, and then what comes up is what's on the right-hand side of the screen. Under that COVID-19 metrics page, there are 3 new pictures: nursing home metrics, school gating metrics, and reopening Kansas metrics. So if you click on the nursing home metrics picture, that will direct you to where the maps, the tables that have the county positivity rates, and that resource is. So that will all look the same, but it's one step deeper in the KDHE hierarchy. And again, I put the map up here from that's published. I pulled this up on Tuesday, I think. So it's this week's map to show you all the green counties that are below 5%, the yellow counties that are between 5 and 10, and then just the one county in Kansas that's over 10% or higher in terms of the COVID-19 positivity rate. So just that's available still. It's just a little different place on the KDHE website. On the next topic about Binax Now antigen tests. So many of you are getting a direct supply of Binax Now cards from the federal government. Maybe slightly fewer as the positivity rates have dropped and the outbreaks are fewer as well. But the Department of Health and Environment ordered a large supply, and so there are more available if that's a resource that you would like to have to either test your staff, test residents when they show signs or symptoms, visitation, a lot of possible needs for those. So these are the same slides we presented last month, just to kind of the steps along the way to get access to those. Again, if you don't already have it, you need a CLIA certificate. You need to figure out how frequently and who you would use these Binax Now cards to test. You order them from your county emergency manager, and the link there in the middle section under order test kits, you can find your emergency manager. You can do the testing. There's online training videos to show how to conduct the Binax Now antigen test, and then you of course need to submit the results that you find through either the resources there, and then there's a KDHE kind of standard operating procedure that they published as well. But those are still available, still for you to use, still available to request if you haven't done it before, or if you have and need more, they're still available, and please take advantage of that resource. And then this is just the comparison between the two ways to present the data on test results back to KDHE. You can use the Kansas Disease Reporting Portal, which is online. You can individually enter patients, or you can do a bulk upload from a spreadsheet. That works as well. Or you can use another tool called Lab Exchange that has a couple of other advantages and features to it if that's something that's of interest to use going forward. Here's a little bit more information about Lab Exchange and how it works. And then there is a live demo there that's linked at the bottom. When you get the slides, you can follow that if you would like. But again, to really make best use of those antigen tests and reporting the results to KDHE, again, that's more testing, more reporting, but these are simplified ways of getting those results into KDHE. So that's the testing part of the presentation. I did want to spend some time on the updates that CMS released on visitation and testing. These came out on Wednesday. There's 2 QSO memos, or the memos that we rely on to understand what CMS's direction is, 2038 and 2039. This does apply just to Medicare certified nursing facilities, but what we've done at KDADS and for Kansas is take those federal guidance documents and then apply them to our state licensed facilities, assisted livings and others, and we're working on that we're working on that now. We didn't get it quite done for today, and there are a couple of places that we need to update different documents, so we're continuing to work on that. Our objective is to have these standards apply to both CMS certified and state licensed facilities in Kansas, so there's one set of rules and standards to follow. So we thought it was worth sharing what the standards are in the CMS memo, and then we'll get the guidance for state licensed out as soon as we can. But what's in the memos on the left-hand side of the slide on the white section is largely what it was before when CMS issued their last update, that talking about visitation, that it's more encouraged than it was before. It ought to be person-centered and based on resident needs. Compassionate care, there's some guidance in the memo about outdoor and window visits. That's largely the same as it was before. There's some pretty specific language about compassionate care visits being allowed at all times. If a resident is fully vaccinated, they can choose to have close contact, including touch, with their visitor while wearing a face mask and hand hygiene. Some definition of what fully vaccinated means, and then indoor visitation. The CMS direction is that you should allow it at all times for all residents, regardless of vaccination, except for a couple of conditions which are listed there in the bullets below. That's all the guidance that's been in place for more than a month or so. That's not new. What the updates this week really talked about is changing some of the standards for vaccinated versus unvaccinated staff members, and then pointed to some CDC documents that will be more relevant on the next slide. But in terms of testing in that guidance, it's QSO 2038, and the update that CMS made there was that there's still a requirement to test staff, but they've modified it to that you only need to test staff that aren't vaccinated, fully vaccinated. So if the county positivity rate, when you look it up on the KDHE map, is 5% or less, you have to test staff once a month, but only the unvaccinated staff. So if you've got staff members that have been fully vaccinated, then they don't need to go to that testing frequency. So they've added the word unvaccinated. That's why I highlighted it in red on the table there. And then that guidance also says that routine testing of asymptomatic residents isn't recommended unless it's prompted by some change in circumstances. So no need for surveillance testing among residents unless there's a confirmed case or an outbreak or something like that. So that's a pretty significant change, that you don't have to test all of your staff members. And again, the frequency has been dropping as the positivity rate's been dropping as well. But to move to just unvaccinated staff is a pretty significant change. In terms of the other change that CMS talked about that's more specific to visitation and communal visits, I clipped out the kind of relevant sections that changed here. Testing of staff and residents. You do have to test people if there's with symptoms or signs of COVID-19, so you need to continue screening. And if somebody is running a fever or a cough or a lot of the other list of symptoms that are in the QSO memo, you do need to test folks then. And then they added this red section under the communal activities and dining. You need to adhere to the core principles of COVID-19 perfection control, but you can start resuming some of the communal activities and dining. The CDC has provided additional guidance on activities and dining. For example, residents who are fully vaccinated may dine and participate in activities without face coverings or social distancing if all participating residents are fully vaccinated. If unvaccinated residents are present during communal dining or activity, then all residents should use face coverings when not eating, and unvaccinated residents should physically distance from others. That's what's in the QSO memo. What I clipped out on the other side of the screen in the blue section is what's in the actual CDC guidance document that CMS refers to, which is largely the same. There's a few more operational details, but that may be worth looking at. But the main element here is that CMS is saying follow the CDC guidance on these kind of communal activities and infection control and long-term care settings. Again, it does create these kind of different standards for residents who are vaccinated versus those who are not vaccinated yet or so far. And I think we're getting some questions about that as well. So we may get to that here in just a second. I think it's the last slide that I've got before we maybe take a minute to see if there are questions we can answer right now, but is about access to long-term care ombudsman and protection and advocacy programs. In the QSO memos, and this has been in place for a while, but is reiterating that the federal law and state regulations mimic this as well, that the state long-term care ombudsman needs to have access to residents, although there may be some restrictions. But then if the ombudsman or somebody from the protection and advocacy agency can't get in to see the resident, there needs to be some other televisit or some other way to facilitate that visit with technology. And then there's a new section about the CARES Act that directed that long-term care ombudsman should have continued direct access to residents through the public health emergency. That's important. Our state ombudsman did release a letter that we helped distribute that I highlighted there on the right-hand side of the slide. They are resuming in-person visits on April 23rd, or at least planning visits and trying to get restarted. They're screening themselves daily and will follow the current core practices for infection prevention during their visit. They'll also follow any facility visitation protocols that are in place, or I'm sorry, they may ask for the facility visitation protocols. The ombuds team that arrives or tries to visit will answer screening questions, submit the temperature checks, and make sure they have enough time to do that. And if you have questions, you can contact our state long-term care ombudsman, Camille Russell, at the email that's listed there. So they let us know about this. We reviewed their memo and think it's consistent with the direction. Just wanted to make sure you all were aware of that as well. You may get requests for the ombudsman to come inside, and again, they've been working on getting their team tested, getting PPE for their team, so they can follow all the appropriate procedures, so they can go in and visit and work with residents as needed. We'll stop and hopefully have a chance for Heather to present here in just a second. But maybe I'll pause and ask Lacey if there are some questions that we can answer, or yes, things that came up in the chat that you want to highlight.
Hello. Yes, I started answering a few of them, and I will publish them as so the whole group can see them. But I was trying to answer them as we went along. One of the, I think a lot of the questions are kind of based around the visitation guidance, and they seem to be kind of specific scenarios that aren't discussed in the visitation guidance, such as communal dining between a staff and a resident, or residents not wearing a face covering while they're walking the hallways, as long as there's no unvaccinated residents within the hallway. The guidance document doesn't specifically address those scenarios. I do think the idea of what they have updated the communal dining to reflect, as far as 2 vaccinated residents being able to dine communally, sorry, without a face covering or social distancing, I think does allow for that bandwidth for a staff member and a resident to do. I would encourage, if you would like to have that specific example, or those specific examples that aren't addressed within the guidance document, to get a solidified answer, to utilize that DNH_triage team. That's the email that's listed at the bottom of the visitation guidance. And you can they have been very quick and very responsive when I have emailed in to maybe get a answer for your community's specific questions that aren't being addressed specifically within that guidance document. The other one that I think I saw was whether or not we as KDADs would be adopting the updates that CMS did within our state guidance documents, and the answer to that is yes. We have not gotten those documents updated at this point. We do plan to update them as soon as possible, but we will be updating the policies and guidances that CMS has put into their documents, as well as the updated guidances from the CDC that was also incorporated into those CMS guidances. I think that's...
Lacey, there are a couple of questions about requiring proof of vaccination for visitors, or how would a facility know whether a visitor is vaccinated? Do we have any insight on that, or do we want to try to take that back as a frequently asked questions and add that to one of our other documents?
I think we can address it now. So the visitor vaccination status, you cannot require them to tell you their vaccination status. So while you may have it as a question, they should be able to answer that they choose not to answer, and it should not be something that determines them not to be able to have a visit. All of the guidance documents that KDADS and CMS have put out are not reliant on knowing a visitor's vaccination status. They're reliant on knowing a staff or a resident's vaccination status. So none of your decision-making factors should be hinging on a visitor's vaccination status. All of the visitation and testing guidelines they pertain to the vaccination status of only residents and staff. You do not have to know a visitor's vaccination status to implement anything within those guidance documents.
Okay. And I know there were a couple of questions as well about reporting the antigen results, and whether, if you're reporting at NHSN, if you still need to report to the state. I'm going to have to read through, we answered that on the frequently asked questions document, and I think the response is the same, but I do want to check that one with KDHE. So there may be some that we need to come back to here in just a minute. But with that, we'll keep looking at the questions. And but in the meantime, maybe we'll ask our guest to present. And Lacey and I, this will give us an opportunity to kind of get together on some of the questions and answers. So Heather, if you wouldn't mind introducing yourself and sharing a little bit of your experience from Presbyterian Manor on visitation.
Absolutely, Scott. Thank you so much for having me as part of the discussion today. Again, my name is Heather Pilkington. I'm the Executive Director at Topeka Presbyterian, and we are a CCRC community. So it's a great privilege to serve seniors here. And, you know, kind of when I think about visitation, the word that I can associate with that is a roller coaster ride. You know, there's a lot of ebbs and flows. There's a lot of swift shifting course. And as providers, we've really had to be flexible in ways that have been a little bit, you know, countercultural as far as shutting the doors entirely and mitigating what that looks like all the way to where we are today with varying layers and levels of reopening and stages and phases. And of course, these are all things that were necessary as a result and a response to this pandemic. And so very necessary for the safety and wellness and health of everybody. But with that, you know, there's had to be a lot of focus on education and communication. And of course, that's not new to our industry. We're constantly educating and communicating. And I think we can all agree with that. But I would say this past year, I've kind of joked, because we have to find the humor in the hard, right? Or else. I've joked, I feel like I've written books and books and books of communication about pandemic processes and, you know, how we're going to implement, you know, the new way of doing things today. And so, you know, that's a lot for the families and the residents to take on. It's a lot for us as providers in the communities and at the state level to take on. It's just a lot of information, and there are many variables that make it even more complicated. To your point, you know, even right now as we're all digesting the new information from this past week, which is exciting, lots of good. I mean, all of this is very exciting, but there's also a lot of details that the hands and feet of the people that are actually acting it out have to ensure are met across every service line, every dotted line, and that can be a challenge. And so for us here at Topeka Presbyterian Manor, it's been a lot about communicating to all stakeholders, you know, making sure that we're really being clear in, you know, the state of affairs at every given time, and the why, and the what that means and what that doesn't mean. And at all times, kind of keeping that roller coaster mentality. We have to be willing to ebb and flow with, you know, we could have an experience where we have to shut the door again a little bit because of an outbreak. that's not a desirable outcome at all, even if it's temporary, because our folks have walked through a lot of trauma and isolation and through the pandemic. And so, you know, the communication piece has been huge. I know when I have an opportunity to visit with families directly, you know, I can send them information every day of the week, or, you know, once or twice a week, but talking with them, of course, like even outside of a pandemic scenario, that one-to-one connection clears up so much that the written word can't. So that would be one of my key takeaways is we can write all the books and they're all important and they all have a place, but we have to make sure we're teaching it in some kind of personal way, a point of contact. And the other thing I wanted to address regarding visitation is while we're managing all the regulatory processes and we're ensuring the safety and wellness, and all those pieces are necessary and important and valid, we have to, at the same time, acknowledge the trauma that our residents and families and staff have been walking through, and they're still walking through. There's a lot of PTSD that has happened. There's a lot of fear of what if this happens again, or what if I can't see my daughter, or what if, you know, my spouse can't come to visit. And, you know, when I've been in some care plan meetings or some family meetings in the last few months, it's been very evident that although it's exciting, people are so thankful to come in the building, and we are so thankful to have them. It's been like Christmas having people back in the building, but they're also kind of the walking wounded themselves. So the spirit of human resiliency has been something I've been just so thankful to see abounding with our it's not that picture, but
Yes, I will. Just a second.
Thank you. I have a.
There you go.
Thank you, Scott. As we're a CCRC, we have our independent living, our assisted living, and our nursing home section of our building. And so we have, you know, we've had several couples that live in different areas of our community. And so for independent living residents, you know, the guidance they lived under was a little different, of course, than the guidance our assisted living and nursing home folks have lived under. And so, but they're under the same community here. There they are, Steve and Kay. I just love this photo because it really represents the journey a lot of people have been on in different ways. Independent living, Steve and nursing home. You know, back to the pandemic, they were able to, you know, connect, hey, have music together, pretty much interactive, their own students. Close God, I'm feedback.
Sorry, I was muted too. So we have a dial-in number 760-5484, and maybe our other guest, Jennifer, if that's you, could you mute your line?
She cannot. Every time she mutes, it hangs up on her. That's the one issue we're going through, Scott. I apologize.
Okay. And I can't mute her on my end, so I apologize for that.
Can you guys hear us in here?
Yes.
Okay, you can hear us. We're good to go then. Every time I mute it, it hangs up on me for some reason.
Oh, I'm so sorry. That's frustrating. Well, we'll keep doing our best. Heather, why don't you continue, and we'll see if we can figure out the background noise, and then Jennifer will open up to you in just a second.
Okay, thank you.
Thank you. Heather, continue.
Let Heather go and figure out how to get on up and going.
Do we have any insight on that, or do we want to try to take that back as a frequently asked question and add that to one of our other documents? But it sounds like if somebody's listening to the broadcast and their microphone is on, so if, I'll see if I can find a way to mute that from my end, but
try to mute our, they say the microphone's on. I can't hear it, I just don't mind.
Heather, are you still there? Heather? Maybe we'll get her back. Jennifer, are you still on?
Yes, Jennifer's
Okay.
still on.
Yeah, and I don't hear the background noise anymore, so well, I'll see if I can.
Okay.
I'll see if I can get Heather back on. But Jennifer Culp from Leonardville, she was going to provide some similar experiences or her experience working with quarantine assessments. So if you'd like to speak for a few minutes, that would be great, and we'll see if I can get Heather back on as well.
Okay, that sounds great. Thanks everyone for letting Leonardville be with you guys today. Just a little bit about us. We are a 59-bed non-for-profit rural facility. We are strongly involved in the Peak community, so person-centered care is what we pride ourselves on. So pre-COVID, we really encouraged our family involvement on a daily basis. So when COVID hit and the lockdown, not only were we concerned about the safety of our elders, but also trying to live as normal life as possible. So keeping them engaged, both physically and emotionally, meant we as a team had to figure out our part and do what we could for them while still following all of our regulations. So our goal was to keep them involved in much as possible, interacting any way we could with visitations. And even though they might look a little different, that was our way of trying to keep them safe and out of quarantine.
Okay, so that was Sue Brunner, our administrative assistant here at Leonardville. She wanted to give a little background information of our facility. So my name is Jennifer Culp. I am the Director of Nursing here at Leonardville. And, you know, along with all of you, we have definitely felt the impact of COVID this past year. Just to touch briefly on testing and what that looks like for us, we are located in Riley County. And we have seen a relatively low positivity rate recently for our area. And though we could be testing staff monthly, we have opted to continue weekly testing just to try to stay ahead of the game. As vendors, therapists, and visitors are beginning to enter our building, and as we are navigating through the guidance and recommendations, we just want to ensure we are closely monitoring the effects of what we are implementing. As healthcare providers, we've experienced the many challenges the virus has presented. However, as difficult as our role has been, I think we would all agree that it pales in comparison to what our elders have endured the past 12 to 13 months. Thankfully now, though, we are starting to see some light at the end of the tunnel for elders in long-term care. I think every facility's visitation policy and procedure will look different dependent upon how your building can best maintain infection control practices. For us at this time, we have initiated the compassion care visits for all elders at all times. We do have a designated visitation area, and we do ask, you know, that they call ahead maybe and let us know that they're coming. That just helps ensure that everyone gets screened and that there's not an overwhelming flow of foot traffic all at once in our building. Though certainly not the norm, it is allowing for that in-person family and friend interaction that has been missing for so long. With those visits being established for elders already residing with us, we wanted to focus a little bit on elders who are moving into our home. For a while, admissions had slowed down, but we are really starting to see an increase once again, and we wanted to address the emotional and mental health of those coming from the community. Not only is there an environment change for these individuals, but coupled with the potential for quarantine and restricted family visitation, the effects can be detrimental. Implementing quarantine measures has most definitely had its place during this past year, and it has at times been absolutely necessary for our elders. However, with more folks being vaccinated and with county positivity rates declining, we were wanting to take a closer look at each individual case to determine whether or not quarantine was necessary. We have seen devastating emotional effects from elders being alone, not to mention the challenge quarantine poses with those elders who have dementia. Thus, we here at Leonardville decided to try to develop a simple elder assessment so that low-risk individuals coming to live with us could possibly avoid a lengthy quarantine upon admission. Let me take just a moment to clarify. The assessment we utilize is for admissions into our building. I know that there may be some questions regarding implementing quarantine measures for things such as outings and such, but remember, in most cases, quarantine is not recommended for elders who leave the facility for less than 24 hours. Rather, that be for medical appointments or community outings with family or friends, as long as they do not have close contact with a COVID-positive individual. But if in doubt, I believe the assessment we're going to talk about could be used in a variety of circumstances to provide that documentation that your facility thought through a situation before coming to a conclusion. Okay, let's dive into this. So our risk assessment that we put together for quarantine is very straightforward and pulls directly from the CDC guidelines that were updated on March 29th, and then from some of the KDAD's guidance that was sent out on March 15th. The goal of our quarantine risk assessment is simply to provide guidance to staff in determining which elders require quarantine upon admission to the facility. The assessment is comprised simply of 6 questions, and it's scored based upon the answers to those questions. The assessment is completed when the elder and family at the time of admission, and they're kept as part of the medical record. The first 2 questions are directly related to COVID. The first question is, has the elder tested positive for COVID within the last 3 months? And the second, is the elder fully vaccinated? Fully vaccinated is defined as greater than 2 weeks following receipt of the second dose in a 2-dose series, or greater than 2 weeks following receipt of 1 dose in a single-dose vaccine. If either one of those questions is answered yes, the elder is exempt from the 14-day quarantine upon admission. Now, if both 1 and 2 are answered no, if the elder has not had COVID, or if they are not fully vaccinated, then we look at questions 3 through 6. Responses to these questions can indicate low risk. These questions include, number 3, has there been any recent known exposure to COVID-19 in another long-term care facility, in acute care, while living at home, in the community, or during transfer? Number 4, did the elder practice infection prevention and control measures while in another facility, in acute care, while living at home, in the community, or during transfer? Number 5, is the county's COVID-19 positivity rate less than 5%? And finally, number 6, are infection practices being followed in the neighborhood at Leonardville where the elder will reside? If the responses to these questions reflect that there has not been a known exposure, infection control practices have been and will be maintained, and the community's positivity rate is less than 5%, then the elder would be considered low risk and would be exempt from quarantine. What we have found in utilizing this tool for admissions is that it is efficient, simple, and user-friendly. Elders and families are able to easily understand what is being asked, and any staff member involved in an admission can complete the assessment. Our end goal has really been to just responsibly determine who quarantine is absolutely necessary for and who it is not. Because if quarantine is not indicated, then we want to waive that, begin compassion visits immediately, and socially distanced peer interaction to allow for a more smooth transition. I think in closing, what we want you to take from this is that each experience and each step forward is going to look different for us all. You know, we went through several COVID-19 outbreaks in our facility over the past year. Even though we passed 3 infection control surveys, one of which was a federal survey, there was simply no keeping a virus that often presented with no symptoms out. The last thing we want is COVID back in our building. It's the last thing any of us want. But if you implement progressive change using the guidance and recommendations as tools, you can make things happen for your elders. and you can make them happen with great responsibility, education, and care. Thank you.
Thanks, Jennifer. That was very helpful and very thorough. Thanks for sharing Leonardville's experience and the effort you've put into it. In the questions, there were several requests for your screening, your assessment tool, and I think we talked about that before. It didn't really work as a slide, but if that's something you'd be willing to share, we can certainly get that out to the attendees.
Absolutely.
As well.
We would be happy to share that. Absolutely. Yes. Thank you for having us. Great. And anybody that wants a copy of that, we would be happy to do that.
Great. If you can hang on the line and maybe just you don't need to mute yourself, but I do want to let Heather, if you're back on and you want to finish your comments. I apologize for the difficulty that we had, but I want to give you a chance to wrap up with Presbyterian Manor's experience as well.
That'd be wonderful, Scott. Can you hear me?
Yes, I can. Go ahead.
Wonderful. Well, I'm so sorry we had difficulty. I'm sorry if some of you are going to hear me start it for the third time. My apologies. And Jennifer, I just loved what you had to share, and I really appreciated what you said at the end. You know, if we're all willing to implement the tools and the knowledge that we have, we can keep moving forward with this in meaningful ways. So I'll just kind of, bounce on that to go back to the spirit of human resiliency is something I had mentioned before. I think we're all demonstrating that, as are our residents and staff and families. We're going to find a way where sometimes it feels like there is no way. And that's why I wanted to share the story of Stephen and Kay. In summary, Kay lives in our independent living and Steve lives in our nursing home section. And when we had to kind of close everything in last year, their world changed significantly. I mean, they're just one story of, countless stories, but there's a special to share because I think it represents a lot of what people felt. All of a sudden, there was no meals together, there was no visits in person, and although we did everything we could to implement very quickly FaceTime and Zoom and window visits and things that we could, it does not replace that in-person connection. And so, Steve and Kay really exemplify wanting to kind of follow the rules. They wanted to partner with us, and they did an excellent job in just kind of walking out whatever processes we had to have in place to make sure we kept everybody safe. And they did that with a lot of grace. And I'll never forget a very powerful moment. I had the opportunity early in December. We were kind of at a height of our own pandemic scenario here in our community, and it was our outbreak time. And I tell you, there was nothing else there's lots to do in the management of the pandemic, but in addition to that, we just had to pray for healing for our seniors and everybody in our community. And so we did a prayer walk around our building, and of course we were socially distant and we were masked, but it was very important to several to do this. And so Kay was a part of that. And I'll never forget being outside the building with Kay, and as we were finishing up our prayer walk, our transportation vehicle pulled into the driveway, and it was in a moment she realized that her husband, Stephen, was in the van. And I just get goosebumps. She hadn't physically laid eyes on him in person in a very long time at that point. And there was just this magical moment of, oh my goodness, that's my dear husband. And he saw her, and the van stopped, and again, everybody stayed in the van, and they did not get in the van, but she was able to see him in person. And I asked her if I could share her story on this call because I think it's very a beautiful story. It's willing to let me do that, of course, but she was able to see her husband, and he was able to see his wife, and that was like this major thing, whereas before that would be an everyday occurrence. What the caused in our lives is great trauma when that becomes nothing. And so Kay kind of walked away from that. We finished our walk, and she just felt such a blessing in her heart for being there at the right time to see her husband. And so this photo that we're showing you is, when we were able to get past the vaccinations and to the point where we could have a hug, her husband. And so I was so excited when that day happened. We were able to kind of share this. I actually, printed these off, and we made sure to deliver one to Kay. This is joy. And we're going to be resilient, and we're going to continue to find the joy in the midst of this, because together we can do that. So I think it's important we don't lose sight of that in the midst of making sure we're dotting all the I's and crossing all the T's. We have to see our folks that we're serving and never forget, you know, what we're doing. So thank you so much for letting me share. It's a privilege to visit with you about this.
It's really a great testament, not only to Steve and Kay and the resilience they've shown, but also all of you that work in this industry, serving the folks that live with you and their family members. It's been a challenge, and we certainly recognize that, but are glad to see these real silver linings along the way as well. So it isn't. It's great to hear, and I that was one of the reasons, not just because I thought we'd find some good stories, but I thought it would be good for you all to hear from each other a little bit when we're distanced and you know, having to do more of these things remotely, but still hear from the experience of facilities that are trying different things and trying to you know, make all the progress that they can. So Jennifer and Heather, thank you both for your comments and thoughts and being willing to share. It really do appreciate it. And if I haven't seen any questions come in specifically for Heather or Jennifer, although other than the request for the assessment tool, so we'll figure out how to get that from Jennifer and distribute to folks who attended. I moved on to the kind of last slide in the deck, which has our thanks for attending, and then the reopening email address. If you want to get an email to us or send in a question, you can send it to that reopening email address. It comes to Lacey and myself and a couple other people at KDADS who monitor the mailbox. We're happy to look at that. I put my email address up there so you can email me directly, and then where we've got kind of our resources tab on the KDADS website as well, where a lot of these materials will be placed going forward. We've been Lacey's been writing responses, and I've been trying to publish them out as I've had a chance to look at them. Some of the questions are a little more technical than that I'm comfortable answering without checking a couple of things. So I believe we can download these questions and then add them to our FAQs or a list like that. Although I'm having enough uncertainty about the technology that if you wanted to send these questions in by email to me to make sure I've got them and can respond to them, I would appreciate that as well. But I think we can capture them even after we end the session. Lacey, are there other ones that you want to just call out here on the audio before we wrap up and give people maybe a few minutes back in their day?
I think the only thing that I would point out is the discussion about needing to know a visitor's vaccination status and what the CDC guidance says versus what the CMS guidance says. And the CMS guidance is what I'm speaking to, and the CMS guidance is what facilities should be following. And the CMS guidance does not speak to needing to know a visitor's vaccination status when looking at the compassionate care visits. That information is found within the CDC guidance. There is a link in CMS's guidance, so I will be emailing that DNH triage team to ask them to provide some more information on that conflict between the link that they include in their guidance and not addressing it within their guidance. And we can put that in an FAQ to publish as well.
Okay, and there's one question in here about doing a joint training with KDHE. That's a good suggestion. We've invited them to this session in a couple of earlier months, and I thought we had enough content that I didn't get them invited this time as well. But I do participate in there. They do, KDHE does a weekly update as well on a variety of topics, but and I didn't hear any comments at that one from local health departments about the quarantine guidance, but I think that was on Thursday and it would have just come out on Wednesday, so maybe not enough time's resolved, but it'll be good to see these questions, and there are some that we need to direct more to KDHE and then have them attend maybe at a future session with us, kind of as we know more, because I think a lot of the questions are about how do you know who's vaccinated or not, different standards for people who are vaccinated and those who aren't vaccinated, and how to kind of navigate those things. So, and they've certainly got that experience at KDHE from schools and private businesses and other things as well. So there may be some other insights that they would have. But that's a good recommendation as well. Scrolling down here to the bottom of the questions. I think we'll probably take them by, there's a couple of comments or questions about the positivity rate doubling over the last couple of weeks, and vaccination, and kind of at what point do you trigger kind of a resumption of reducing or limiting in-person visitation. Again, the guidance talks about trying to keep facilities open to visitors as much as possible unless there's an outbreak inside the facility, but it also then says, but you've got to use all the information that you have to make those decisions. So it's a good question. I think we'll need to read a little more closely about that one. But if there are any specific questions for Heather or Jennifer, I didn't see any get typed in that I can see, but give it just another minute or so. Did you see any questions that were specific to Heather or Jennifer's presentations, Lacey? I don't think she did. Okay, well, again, just thanks everyone for attending and asking questions. If there's one of those that you want to make sure we answer, if you could email it in just as kind of a backup in case we can't get all the questions downloaded from the Q&A. Thanks for your patience as we tried some different technology along the way. We'll keep doing our best to practice and improve. And then lastly, thank you to Jennifer and Heather for sharing your experience and being willing to share that information with your colleagues across the state. I think I didn't see a lot of responses, but the couple that came, the questions were positive as having that opportunity. And it doesn't always have to be something positive. If there's some things that KDADs could be doing better, we're happy to hear those comments as well. But Jennifer and Heather, thank you for sharing your experience, and leading age and case for making you available for the webinar. And with that, again, we'll take the questions down. We'll be sending out the slides here shortly, and figuring out where the recording will go if you want to watch this a later time and re-experience the audio and video problems, and get some of the good content, and definitely the great stories from Jennifer and Heather. That's probably the highlight for my week, to hear their experiences. So again, thanks for your time. Thanks for attending, and we'll talk to you all again very soon. Thanks.